Ladies and gentlemen, welcome back to Healthcare Uncut, Unfiltered, Episode 3. We're excited to be back. It's been a hot minute again since we've been together. We've had a lot of things going on in our lives. We've shot down spy balloons. We've had train derailments, and I know that's not what this is about, but I've got a big smile on my face right now because I love Brandon Lovelace's theory on all that's going on. But let's put that all aside for a couple of minutes for us to have some good banter, good conversation, and deep insight into what's going on in the landscape of healthcare and how it's impacting employee plans, how it's in fact impacting people who are on or off employee plans. I'm here again with Brandon Lovelace, Alex McDonald. I was made aware on the way in that we've got a story. We've got Alex wants to throw us we'll call it the riddle me this category. Alex, tell us what's on your mind.
Well, so I'm trying to figure out how to approach this, but basically, I'm going to tell you guys a story, and I'm going to ask you how that relates to what we're doing, and is it a success or not? Right?
Okay.
So there's a employer plan in Texas that went to, it's a group of teachers that went to Baylor and negotiated a rate for 3 weeks of hospitalization a year on a flat rate per month price. I don't know all the details of, complications or anything, but I think it's just 3 weeks in the hospital for any reason. Maybe there's exceptions of, childbirth and some other things. But so this plan came about because the teachers union or whatever this came through was having trouble paying the bills, the hospital bills. So they negotiated a flat rate, which is very free market and very does align with what we're talking about. So this plan is implemented. Then some other hospitals heard about it in different parts of the country, and other employer groups heard about it. So they start doing this as well. And there's this flat rate for hospitalization.
It's Baylor Scott White.
It's Baylor.
Okay.
Yes, I'm not sure if that's all.
That's all one big system down there, and they're a monster.
Right. So, this is now part of their plan. They can go to the hospital up to 21 days, cost free. Hospitals covered it. Then across the other side of the country, I believe it was in either Washington State or California, I can't remember, but a group of primary care physicians form a similar deal with some other employers, which is we've already talked about with direct primary care. And this is now spreading. These two groups' plans are spreading across the country pretty rapidly now. Now, the kicker to this story is, do you think that sounds in line with free market medicine and what we're speaking about on this podcast?
To me, it does. To me, at first glance, at the tip of the iceberg analogy we always use, just on the information that you've given me, anytime you can go out and negotiate a direct contract in a scenario like that, and I know the Baylor Scott White facilities are not interested in negotiating off of Medicare and things like that. They don't want to be backed into a corner. They're big enough where they don't think they need to be told how much to charge for their services or take reference-based pricing stuff. Now, there have been some negotiations that I've heard that Baylor Scott White's allowing some RBP to function, but they're not kind in that marketplace. So if they're negotiating 3 weeks of hospital stay, and there's more to it, I'm sure. But if they're negotiating...
Well, let me read you a quote from Baylor.
Okay.
This is a quote. Baylor uses no sales agency or middlemen, but prefers to deal directly with the group so that all group hospitalization fees paid may be used only for hospital care of members and not for any personal profit. Okay? So, that story is from 1929.
Oh, wow.
The organization chose a symbol to put on the outside of hospitals to say that this is a hospital that participates in this direct contracted health plan. Can you guys guess what that symbol was?
I'm going to guess the Red Cross.
Close.
A cross.
Closer.
A cross with some sort of ribbon.
The group across the country that I mentioned of physicians, they had a symbol themselves that said, we're a part of this physician group that accepts these direct payments.
Okay.
The hospital symbol was a blue cross. The physician symbol was a blue shield.
Mm.
And that, my friends, is the story of how Blue Cross and Blue Shield started.
So what you're saying is similar to how Apple started in this industry as in their respected industry as someone to break up all the different tendencies that companies had. They were the little guys, and they were saying we need to do what's right by everybody and let everybody have access to technology. Let anybody learn how to make new software. But along the way, they kind of became a corporation on their own. Is that what's happening here as well?
Well, that's similar, except for the fact that this time in our country, there was no health insurance. So literally, that plan with Baylor and a Baylor hospital administrator that went to this teachers group, or I don't think it was a union, but it was some state of Texas employee group. They weren't able to pay their bills, so the hospital was not doing well. And so he had this idea of, what if I went to this group and said, hey, if y'all could pay, and it was $6 a month to get up to 21 days covered. That gave Baylor a steady stream of income to run their hospital, and it gave coverage to the teachers so they wouldn't be scared to use the system, to be scared to go to the hospital and not be able to pay their bills and disrupt anything. So health insurance didn't exist. Now, the reason I bring that up is, one, because it's obviously insanely ironic that Blue Cross and Blue Shield started under free market principles and for the community and for the entire purpose of providing low-cost health care and making it available to everyone in the community. Like, there's all this stuff in this little paper that I printed out of the history of Blue Cross and Blue Shield. They didn't merge until much later. The physicians actually, the Blue Shield portion was actually somewhat, it had a little bit of greed in it. They were scared they were going to get lumped in with the Blue Cross plan, which was very cheap and very much directed at nonprofit.
It was a mech type plan, I'm sure.
I don't know what that means. What's
Minimum essential coverage.
There you
That's
go.
all.
Sure.
Yeah.
Yeah, so they were trying to provide a solution to people needing services and not be able to pay for them. Mm-hmm. The physicians were like, well, wait a second. We're prestigious. We make our money, and we want to shore that up. So we want to negotiate our own prices. So that's what they did. The history of healthcare in this country is fascinating. I went down a pretty deep rabbit hole, but it really wasn't until much later that, and really when the government got involved, mm-hmm. is when prices really started going through the roof. It went along pretty well, and I think somewhere around, I don't know, it was a large percentage. It's like 80% of the country had some portion of these Blue Cross and Blue Shield plans available to them. Employers were helping cover it. And then eventually the government got involved in the sense of they needed more hospitals. So they passed a law called the Hill something Act that put county hospitals all over the country. And then fast forward how these hospitals are going to get paid. So I think that was in mid-'60s, and then in the early 60s, and in 66, I think Medicare came to be. And that was an attempt to provide insurance for the elderly, although I've read some conflicting things, but the elderly already had insurance. So it was sort of a bait and switch of they need insurance, they don't have it, so we're going to provide it through the government, but really most of them did already have it. But once that happened, you had healthcare prices start to skyrocket because now the government is the payer. And once people realized they could dip into the taxpayers' bucket pricing went through the roof. Charge what you want, get paid what you charge, and here we are. I don't know if you can Google it, Brandon, but if you look up there's a chart out there that shows like the increase in healthcare expenditure in the U.S. versus administrative expenditures in health, and it's stunning. Like there's, and I think they even have physician growth. Those are the 3 lines on the graph. But basically, you have a really small amount of growth of number of physicians in the country. I say that over from 1960 to, I think the charts to like 2010 that I saw. Let's see if it's up here. But the
must be it right
physician amounts have like doubled. That's the expenditure. You can see obviously it goes up, but it's as compared to administrative health costs. But anyway, physician numbers have like doubled, and it was like a 2,300% increase in administrative costs.
Jeez,
it's insane. Or no, it's 3,300%.
In administrative costs to run it.
Yeah, like from the time,
course.
From the 6th passage of Medicare to now,
Yeah.
there's been a 3,300% increase in administrative cost in healthcare.
Is it because they're hiring so many more people, Alex, or is it because,
Well, yeah,
or because they're just really greedy, or because the government doesn't need to be involved in any of it?
Both. I mean, the point it shifted. There was another significant piece of this story, which is Blue Cross was a nonprofit, very benevolent company, and it wasn't until I think in the early 90s. Well, before that, they allowed people to basically franchise or be a part of the Blue Cross. You could open a Blue Cross Blue Shield agency in Ohio and in Texas and in wherever, independent Blue Cross agencies. But they all had to adhere to the rules. Like the rules in Texas were no more than 15% of your money could go towards administrative costs, and even that 15% had to be approved by the state of Texas before you could spend it. It was very regulated, on erring on the side of the patient or the people paying the premiums or whatever you want to call them. Some point, one of the agencies in California was trying to start a for-profit company underneath the nonprofit agency, and it caused a bunch of turmoil. End game was they just approved that they could be for-profit, and once that happened, now you have the system we're in now.
Do you think we have enough data to track back where it specifically happened? Do you think if we spent like hours just researching this data, you could like pinpoint one person that just...
Well, a lot of it's in this report, and maybe we can put a link to it on our social media and on below our video. But it's a very well written. It's just a history of Blue Cross Blue Shield, basically. I mean, that's all it is. But it does pinpoint a lot of players in the game. It doesn't really go into too much into the federal government side and the history there with Medicare. Although Blue Cross, when Medicare was passed, each state could hire an administrator of that plan within their state, and
Right.
I think 80% of the states chose Blue Cross to administer the plan. So that's really how, and I don't know if that still works that way to this day, if Medicare just administers Medicare themselves, or if there's still independent agencies that, as a TPA almost would administer the plan. But, point being, they went from being what we're talking about, the very thing that this podcast exists for, to being what they are now. And it's fascinating because it all started in a free market in order to provide services to patients who could not afford them, and made sure they kept them affordable.
Yeah.
Fascinating story.
It is. It's a great story, and I see it now as the inverse. What's happened is these doctors that were not in a health system saw an opportunity in a health system if they pooled their money to create a bigger pool of money, obviously. But now enough water's under the bridge, and we've gone through and healthcare's changed. Blue Cross and Blue Shield's become the behemoth that they are, and they're not a health system now. They were initially a health system and a group of doctors, if what based on what you're saying. But now what we have in this marketplace, from that free market to this free market, is doctors leaving health systems as fast as they can. And it's the direct primary care movement. And so it's the opposite. We got to get out of this health system. They didn't know what they didn't know when they said, hey, we want to get in this health system. The health system takes control, and they have more areas in which to create revenue at a health system than maybe a doctor does in a doctor's visit. So the wild part of it to me is it's a inverse of how it started, and that we're wanting to undo or unbundle what they bundled up back in 1929.
Well, yeah, I mean, they've always been the plan. I mean, they're, they went to a system, which really was, maybe Baylor had more than one hospital, but eventually they created a system of hospitals. But they were always the plan that you join to be able to access that, which is really what they still are. And as much as I, think there's so much negative about, we've been talking about Blue Cross Blue Shield, so we'll keep doing that. But all the BUCAs, all the big carrier networks, I think there's a lot bad there. But at the end of the day, their only job is to, well, not only job, but a big part of their job, if you boil it down to one thing, is like, how much do I have to charge people to access this plan to where I'm not going to lose money when the plan has to pay out, right? Now, behind all that, you've got an increase in cost a year over year over year over year. So every year they have to increase their premiums to cover the increased cost of the hospital systems that are increasing their cost. For what reason, I don't know. But it's not based on the hospital's cost. It is a little bit. But if you can just write a blank check to yourself and say, hey, I've got this big hospital, guys. Like I really got to pay for all this stuff, and so I'm going to charge, $1,000 for that instrument.
Well, that Tylenol.
What'd you pay for that? Like it's not based on overhead or real things. It's really just based on, at this point, it really is how much profit can we make, because they are for profit. Even the nonprofit hospitals are for profit. They're not trying to, squash costs down to the minimum so that their community can access their hospital.
Brendan, that's the pivot point. That's the tipping point right there. You just said it. The tipping point of this whole thing was they started out in a philanthropy, in a 501c3, a not-for-profit. And when they determined that they could become a not-for-profit, what was the modus operandi at that point? It became, let's make some money. Mm-hmm. And it quit being about delivering care at a reasonable cost. And that's the beauty of what I think we bring to the table with the health plans we're talking about, is we deal with a guy like Dr. Smith, and we'll mention him over and over on this podcast, but he's sick of that. He was sick to death of that. And he said, I just called a bunch of surgeons and said, how much would you do the tonsillectomy for?
Yeah.
What would it take you to get out of bed, flip the lights on, and come down here and do a tonsillectomy? And they gave him a price, and he added a number to the price to cover the administrative fees of the surgery center. And he told those guys, I'll pay you that if you'll be a member of my staff, not staff, but on call as a surgeon here. And so that's the way they started. They've gotten to a point where they decided we needed to be for profit. And then all of a sudden we've got ourselves trying to unbundle that now. We got I say ourselves, and it's really kind of a general way to say it, but we've got a movement in America trying to do things differently than that, because it's spun completely out of control.
When it comes to bundling, are there any examples of good bundles? I mean, anywhere.
Progressive.
Yeah, what does that even? Whenever I think about bundles and things, I think about like my parents have a bundle with their cable company, and it is the worst deal ever, and it's categorized as a good deal, and they have no idea because that's all they know. But even when it comes to health bundles and things like that, Where does it probably started in a healthy manner? It probably started with this good intention, but
Yeah.
but is bundling?
Well, we're defining bundling in two different ways. I think when Mark's saying it, he's unbundling the current system, the way it's set up,
Right.
And bundling where you have to sign up for a health plan, you have to pay your premiums, you have to do X, Y, Z to even begin to have health coverage. But within our world of free market medicine, bundling is actually exactly what we do, and it's better for everyone. Meaning, we'll talk about Dr. Keith Smith.
That
quite
$3,000
a bit.
tonsillectomy, Alex.
Right. So he's bundling a group of services into a single price that's fixed. So if you go to the hospital and get a tonsillectomy, you're going to see if you ever see it, but an EOB, an explanation of benefits, that line by line shows what happened and what was used and what the surgeon cost, and the anesthesiologist, and the gauze and the Band-Aids and the antibiotics,
And the love and the
pain
care and
pills
the-
Right.
all that. It's a price by price by price to get a total. And what bundle means in the free market world is that doesn't happen. There's a price, and it says basically everything related to your tonsillectomy is covered under this.
Yeah.
You don't need to know how much we're charging for a Band-Aid, for some sutures, for whatever. It's just all bundled together. But unbundling what's been done is, I think, how Mark was using it.
Yeah, they're deconstructing it.
Right.
Yeah, it's two ways for sure. I get that. That makes more
Yeah.
sense now.
That the pricing in healthcare today is unbundled, meaning it's line by line by line. Everybody's heard of the $500 aspirin at the hospital. You start looking at what they're charging you
A pillow.
for every little thing. It's 45 minutes in the recovery room is $20,000, and and you used a pillowcase, and that's $85.
Yep.
And I mean, literally, it'll be that detailed. That's how it's billed today.
Traditionally.
What we think the way it should be, and the way it's being done across the country, is saying no, like we're not gonna like unbundle all that. We're gonna put it all into a package price. That, unlike your cable bill and your phone bill and all those other things, it is good to bundle it because it's cheaper. And not only is it cheaper, it removes all the doubt. It removes all the, what are they going to charge me for
There's some accountability.
the extra little things.
Yeah.
These prices say, you know what, even if there's a complication, even if you need multiple follow-up visits after, these are all covered in this price. There's no waiver from what we quote. What we quoted you is our price, and that's the end of the story. And in a way, the free market surgery centers, or anybody participating in that, they're putting the risk on themselves in a way, like an insurance company would, because they know there's going to be complications. The surgery for a young, healthy individual who eats right and exercises is much different than an elderly, overweight,
Diabetic.
or somebody with comorbidities of any kind. Those are two. Even let's say they're both getting a tonsillectomy, those are two very different tonsillectomies about to happen.
True.
One is more than likely going to go smoothly and everything's fine, and the other one is very risky and could have some complications. But the bundling that price together is saying, I'm going to take confidence in my facility and my surgeons and decision making up front. There might be a case where they say, hey, you really can't have this surgery until you're able to be put under anesthesia without risk. I mean, this is and I don't know how hospitals make that decision versus a surgery center versus a free market surgery center. But I would imagine they're a little bit different. If you're driven by the revenue and the emotion of the patient's safety, I don't want to say it's out of the equation, but if it's moved down underneath profitability, you're going to bill it either way. And honestly, complications make you more money. So who's more motivated to go ahead with a complicated case. It's somebody's motivated by money as opposed to the health and safety of the patient. But all that being said, bundles in the free market world are a very good thing. Like at our imaging center, we bundle the actual time in the machine and the data from the machine with the radiology's reading. There's not two bills from our center for the MRI and one from the radiologist for interpreting it and writing that report. It's all mashed together. That one's a simple one. But when you get into
a hernia, you get into
Yeah.
a hiatal hernia surgery. There's a mesh and there's a piece of durable medical equipment that goes with it, and there's some post-operative care that needs to be done, and there's recovery room time, and there's all this. Anesthesia is the big one. The vast majority of the bills you get having a baby, you'll get a separate anesthesia bill because they hold the hospitals hostage, which is genius to me. But at the end of the day, Dr. Smith's an anesthesiologist of all things. But what happens is they have to, you have to be able to dissect and break that down. And once you get all the bills in and you put the reason people are crippled by medical debt, and I know I just segued, but the people are crippled by medical debt is because the bills don't stop coming. The bills just keep coming. And oftentimes everything that's on this EOB doesn't include something else that they've decided to bill for. You can figure out quickly how you're going to be taken care of financially whenever you learn what is going to happen in an office setting, in a doctor's office. These doctors that are working for health systems like Integris or like Mercy, they are clinically trained. They are trained at their core to turn an exam room over in 7 minutes. That's not driven on patient care. That's driven on revenue. We've got to get this office to see more people throughout the day, and 7 minutes is the number that they say you can turn them over. And if you go to the doctor and your throat's sore, but you twisted your ankle walking in, and you want them to look at your ankle too, that's a separate appointment and a separate copay. They may see you there if it's under your 7 minutes for another copay, and hit you up again for that diagnosis or that visit. So it's just it's nuts to me that bundling isn't happening everywhere. It isn't just the way that it's done. And it goes back to the idea that they stopped being a benevolent organization and became a for-profit organization. And whenever you're a benevolent organization, you're all about giving money away and taking care of the people and doing things to make their lives better. Whenever you cease to be a benevolent organization, it's about revenue. And as long as that's the driver and they've gotten themselves in the situation they're going to be hard to beat. They pay lobbyists in the White House and things like that. But as long as that's the way it's going, it's never going to be in the interest of you or me as a plan member on a Blue Cross and Blue Shield plan or an Aetna plan or a single plan.
And I think the big key here, at least for me, is the major difference is the government, whether that's federal, state, even county, maybe even more local. Because they're involved, and obviously the federal government's involved in a massive way in healthcare, the free market principles just don't work. Which is why what we're doing is I think it's so important, because we're basically saying, no, let's just forget about all that. Let's start doing it the way it started. Mm-hmm. Let's go back to the basic principles of, I can go find a provider and I can negotiate a rate with that provider. And if that provider says, I don't do it that way, well, then we go find another one. And that's the free market at work. Mm-hmm. I don't think doctors, actually I know, doctors don't enjoy having to write 10 diagnosis codes down for 10 different visits and bill 10 different things and collect 10 different times and collect 10 different copays. And they do truly wish, and Brandy could maybe speak to this, his father's a physician, but they wish they could just sit down with the patient and talk about what's going on and try to figure out what's the matter and try to help them and then get paid for that. Instead, they do have to think about, what can I do to help this person? And I need to spread this out? Do I need to move this to another visit? Do I have time today? I've got a waiting room full of patients and I got to get through this. And then when they decide to do something, they might even think about, can I do this? Like, what if they don't approve the MRI? What if they don't approve I'm going to do this thing and I might not get paid for it. You know, that's the opposite of what we sometimes think, which is I'm going to order everything possible and make as much money as possible. And I don't really think most doctors don't think that way. I think some of them do when they do own their own equipment and things. And I honestly think that's okay. I mean, those services, as long as they're ordering services that are needed, if they happen to have that service available in their office, then good for them. You know, but I don't think they enjoy all the hoops they have to jump through to just be a doctor. And I think stripping away all of that,
the bureaucracy,
as you mentioned earlier, direct primary care is doing that. It's that Baylor model. It's saying, hey, I'm going to pay you a flat rate per month, and it's not even capped at 21 days in a hospital. It's you can see me anytime, you can call me anytime, you can text me anytime. I'm available for that flat rate a month. You can come in every day. You know, it covers all your costs, and it's beautiful. And I know a lot of direct primary care physicians. I see one myself.
I do too.
And they're happy. They love it.
Great guys.
They
Great doctors.
are able to be doctors again.
I'm going to give a shameless plug to mine, Dr. Jeff Davenport at One Focus Medical. I'll tell you right now, my average visit with him is 35 minutes, period, end of story. And I talk about everything that's going on in my life from a health standpoint. Now, I don't go see him all the time. And I will text him a picture. My dad sneezed at Thanksgiving and had a big blood vessel pop in his eye, and it was bleeding, or it was bloody looking. And I sent him a picture of it, and he told us, "Don't worry about it." And it, just that having that access and that peace of mind.
It's amazing to say it, because this has been my whole life. This is all I've ever known, and that's novel to you. That's like, oh my gosh, I can tell. Like my dad is a retired ER physician, and my whole life it didn't like. I fell off the slide when I was 7 years old. We had a little slide going into a pool, and I fell off, hit my eye, and cut it open. And in 5 minutes, I was on my kitchen table with a few towels underneath me and getting stitched up. Like that. That's my life, you know. So it's a wild thing to hear that the majority of the world doesn't have that. And even if you do have a relationship with your doctor, it's not always a relationship that you feel comfortable texting like, hey, is this rash normal? Hey, is this? But you have to. It is so nice. There is nothing better than being able to do that. To be able to say like, hey, look at this rash on my kid's leg. Like, should I go to the hospital? And for him to say, and not have to worry about like the liability of what I'm about to say. Because if you call any after hours doc at any time about any problem, I hate to say it, but they're just going to say, yeah, you should probably go in. That's protecting themselves in many ways, shapes, and forms. And for me to be able to just have a resource like that, I've taken it for granted for so many years. But that is precisely what you're proposing in is a direct to care. What is the system called? Direct care physician?
Direct primary care.
Yeah.
Direct primary care. If employers are listening, if there's an employer out there listening right now that's dealing with an out of control health plan, their specialty meds are going through the roof. Their increase is 12, 15, 17. The average increase we've seen this year is 17%. If they're dealing with this and they want to fight it, the only way to fight an increase is to lower claims, is to quell, stop, and lower claims. The best way to lower claims is to put your employees in a position to consume health care where it does not become a claim. I'm going to get to where I say this on every episode, and I love how that sounds, and I think it's great, but it's a light bulb moment for a lot of employers, and they don't understand it. They don't get it. Every employee wants to go to their doctor. I've seen my doctor since I was 17 years old. This is my doctor. I don't want my doctor. Well, the minute you need something at midnight and your doctor doesn't want to help you and he tells you to go to the ER, you'll look at another doctor. I've seen it happen over and over again. But the employer, if you're listening, here's how I'm giving them a golden nugget here. Here's how you lower your renewal every year. I don't care if you're fully insured. I don't care if you're self-funded. Give every one of your employees a direct primary care doctor option and pick up the tab. It's $70 a month, $80 a month is all it costs. And everything, the vast majority of everything that occurs in that doctor's office does not generate an insurance claim. And you can go to them for about 80% of anything you would go to a doctor for in fully insured marketplace in a health system, and it would all generate a claim. Everything would generate a claim. Your bloody nose would generate a claim as much as your broken arm would generate a claim. And that's the thing to me is it's so amazing. I don't know that I've ever filed a claim on my company insurance, and I'm on a fully insured healthcare plan. We've got 1,200 people, and they fully insure them. Alex,
So that's fun.
yeah, we need a sound effect machine where you have a toilet flushing or something along those lines.
Well, they get a commission on it.
Right? Yeah, exactly. Yeah,
There's some applause.
Yeah,
We
there
got some
you go.
applause at our
I
fingertips.
love that we've got that. That's awesome.
Well, another thing you're along that same lines is not just reducing claims, but it handles those folks that haven't been to the doctor in a long time and have chronic conditions that cost large claims. Like, say, for example, diabetes. Unknown diabetes. If you have a diabetic in your workforce and they don't know it, I think I'm going to go off memory, so if I'm wrong about this, sorry, but it's somewhere around an extra $12,000 to $15,000 a year that you're paying in healthcare costs because they're treating it themselves. Whether they're going to urgent care or the ER, they're gonna need things fixed, but they don't take care of it because they don't know they're diabetic.
They're
Now,
not
a
relating it to that,
diagnosed diabetic that is in your workforce that is not managing their care is a little less than that. I think it's somewhere between $6,000 to $8,000 a year extra. But a managed diabetic is much less than that. And when you give them an option, a physician that doesn't cost them anything to go to, you can see them as often as you want. And these direct primary care physicians are your physician, like for real, like text, call, or they have an app or whatever that helps you communicate with them. But most of them give you their direct phone number.
I have mine.
And you can call them and talk to them whenever you want. But you're not afraid to go to the doctor anymore because it doesn't cost anything. And that physician, your new physician, will say, hey, let's get you tested. Let's figure out what's going on. They do some blood work. Oh, you're pre-diabetic. You're diabetic. I went in. I was pre-diabetic, right? And no idea. I don't feel like I'm a super overweight person, and I felt healthy, and I take care of myself in general. But I was pre-diabetic, not diabetic. So I'm like, okay, what can
It's all
we do?
that bacon you're eating.
Oh, I love bacon. But he prescribed metformin, which at first I was hesitant. I'm like, I don't want to be on any kind of meds or whatever. But I looked it up and did some research, and metformin actually has a lot of like longevity benefits and some other things. I'm like, okay. And so I said, write me a script. And he's like, well, I can give it to you here. I'm like, oh, well, okay, but I can't run that through my insurance. And he's like, well, we'll just see how much it is. And it was like 60 pills was like $3. I'm like, well, yeah, I can afford that.
Can I get a 90-day supply?
Give him like $3 and I'm out, with my 2-month supply of my meds. And I didn't have to go to the pharmacy. I didn't have to pay the co-insurance or whatever. Happy to do that. But when I did not have a direct primary care physician, I didn't go to the doctor unless I really thought,
we're men, Alex. We don't go to the doctor.
Well, right. Agreed. But it's also because it's silly to go spend money on something. I know I'm sick. I got a little virus.
How am I going to pay my golf membership if I'm paying
exactly
medical bills?
Now, there's a bundle we should talk about. A golf club, medical club, bundled membership. That's how this should happen. Complete with whiskey on the shelf and bourbon.
I think you'll actually start to see some interesting movements in this country. Maybe not that, but maybe. I mean, I think this is going to end up being a movement that starts to bundle together a lot of services in one spot. Where we've even talked about it. At least Mark and I have in the past. I mean, creating a one-stop shop or series of shops that include, so like the place I work at, we've got medical doctors, we've got all the diagnostic imaging equipment, we've got physical therapy, we've got an interventional radiologist that can do pain management procedures. Imagine just a bundled price to use that whenever you want, just like direct primary care. Now, I'm not smart enough to put the math down.
I'd pay $200 or $300 a month for that.
But
I'm gonna lie to you.
All those services are not anything that is unpredictable. The most unpredictable thing might be the pain management where they're doing like spine injections and things, and those sound scary, but really they're pretty simple. So on all these services that healthcare includes, and I don't know, we could look it up at some point, but what percentage of things are like just almost like, you know the cost of them, you can predict them. There's not going to be any complications, or at least rarely are there complications. So what price can we put on that? I think that's the pieces that are currently under the free market medical world are being put out there, where it's, some physician or physician group or a medical group says, you know what, we can come up with a price for these things. I get it with inpatient hospital stuff. Some of that stuff is insanely complicated and it is expensive. The equipment's expensive. There's new technologies that come out that help with those things. There's new medicines. I get all that. But man, these things that, have been around for a long time.
Bundle them. Charge one fee.
You know what you paid. You probably paid it off by this point. Lower the price on it, just like any other industry. And that's what's happening. And that's what Mark sells for a living. He puts all that together and says you can add the minimum of direct primary care all the way to the maximum of full outpatient surgeries covered and more, or anything in between. And I'm on the side of figuring out what types of services make the most sense and what can we provide at that price. We're currently adding direct cardiac care. We meet with a cardiologist. We've got obviously an ultrasound machine to do echoes. We've got stress tests. We've got EKGs.
You know what's crazy about what all y'all have is it's easily accessible through Connect Benefit. Mm-hmm. You can get to those kinds of things. And if you're an employer and you want all those things in one spot, if you want a continuum of healthcare outside of maybe renal, and you want to know that the price is contracted, you want to know that you're going to get a solid deal, you can bolt on a care coordination program to your employer benefit plan. And if you've got a direct primary care doctor and he knows about your care coordination plan, it gets even better, because you go to the doctor and you say, I've got, you get your diagnosis, and he says, well, here's your care coordination. We're going to go over here for your MRI. And all of a sudden they're going to Alex for an MRI. And next thing you know, if that MRI says I need surgery, they're going to Dr. Smith for surgery. You've taken a referral through the path all the way to healthy and never gotten into a PPO, I don't know what the hell the discount is, model. You've stayed into a predetermined price model, and you can budget for everything that they did. There's nothing in that travel of that referral that is outside of there's no stepping off point where there's an imaginary number that they can apply to it. They're not in a hospital. They're in a surgery center. They're not in a hospital imaging center. They're in a independent imaging center. It's primary care is the rudder that helps us move that referral into a position to where they get healthy without ever stepping into a system. It's back to our last episode. It's consuming healthcare from a consumer standpoint and not a systematic standpoint.
Right. And back to the beginning of this episode, it's that 1929 Baylor model. Mm-hmm. It's an employer saying, in that scenario, the teachers were actually paying it, but eventually the employer, mm-hmm. the state of Texas, paid that bill. But the employer saying, you know what, I can go pay this flat rate, I can budget it, and I can negotiate that with the provider. What is that cost? And the provider says, you know what, it's $6 a month, and I'll give you 21 days. And then maybe I don't know if they negotiated on day 22 if it was XYZ cost. I don't know, but that's what it is. It's, you can go, you could do it all yourself. You could call your primary care physician and say, hey, will you take a flat rate per month? They'll probably say yes.
Yeah.
Or you can call somebody like Mark, talk to your broker that you have now to ask them, like we've talked about in previous episodes, if they know about this and can we implement this, because there are Connect benefits out there. There's the Jay Kemptons of the world.
Absolutely.
There's
KPP
people
free.
all over the country that have already done this legwork for you to negotiate all these rates for you. They're published online. You can see them before you buy them. And there's no reason that you shouldn't be doing this. I mean, literally zero reason that you couldn't implement a piece of this, if not a full-on, fully covered direct plan.
I can show you how to wade into the pool, or we can get on the diving board and bounce as high as we want and dive right in. It's that simple. But I'm going to segue us from that. It was a great wrap-up on what you brought to the table, and I appreciate the history lesson on Blue Cross and Blue Shield. It's incredible. I did not know that that's how it started. But going down, and I know you've got somewhere to be. You were on call for a tonsillectomy.
Yeah, we've been talking a lot about tonsillectomies
Yeah.
today because my son just had one, but it all still plays into it. You know, the amount I learn every week here is just better educating me to continually make better decisions on healthcare, and better decisions equal spending way less money than I need to and having my family be way more healthier than they currently are. So
Sure.
I appreciate you guys a ton.
Glad to
We'll
do it.
put a little teaser too. You're going to get a bill at some point, or an EOB. I know you have good coverage, so hopefully you won't pay anything out of pocket. But bring that in.
Yeah.
Because I want to see what, wherever you had it done, what their charges were
Sure.
for that. And
We'll break it down.
And we looked it up before we started recording today, but Surgeon of Oklahoma does that procedure for $3,710.
Out the door. That's done.
That's all in, all anesthesiology, the procedure, everything.
You don't have to bring.
Follow-up
You don't
visits.
have to bring $3,712 or $3,722. You have to bring $3,710, and you're done. And that's it. They're not going to charge you for another thing.
I'm interested to see when that bill comes in, you get an EOB. We'll see what the difference is.
Yeah, that'd be fun.
It'd be interesting.
That'd be fun. Who brought this? Who brought this today? This bourbon.
This spirit that I brought today has a direct primary care connection. It was given to me whenever I started at Relation, with my company that I work for now, and it was given to me by a gentleman named Matt Tipton, and he gave it to me whenever I closed the 1200 Life group. It was a pretty monumental, successful moment in my journey, and Matt was right there. I office with Matt, and he aggregates primary care doctors, direct primary care doctors under one payment system, so that me, as a consultant, I can talk to an employer and say, hey, we'd like to implement direct primary care with your plan. We think it's going to save you the most amount of money. And they go, well, I don't want everybody to have to go to the same doctor. No, you don't have to do that. We've got doctors from to choose from, and it's called Duple is the name of it. It was PL Providers before. They've gone through a brand change. It's gone to Duple, but basically you can go on their website and you can choose a provider, and you can read a big bio about any direct primary care doctor that's contracted with them, and you
How
can
does
figure
one
out how you
spell Duple?
DOOPL. Duple.
Okay, gotcha.
Yep. It's a cool branding process
Nailed it.
they went through. They interviewed a lot of people, talked to a lot of folks. I'm excited to get it broken out. I want to have them on as a guest at some point. I think they will be very enlightening, and we can pepper them with the questions that we think we want to have answered. We think our listeners might want to have answered. But the spirit itself is Calumet Farms Kentucky Straight Bourbon Whiskey, single rack black, aged 12 years. I've had a little sip of this sweet spirit. It's amazing. I'm anxious for Alex to give it a shot. But it was given to me by Matt. It's kind of got a special place. That's why it's not empty yet. We pour it up on special occasions, and it's a pretty good tasting bourbon. You'll get some good notes on this. So it's ready to roll for you guys. Cheers.
Thanks for bringing it.
Yeah,
Uncut,
cheers.
unfiltered, healthcare.
Cling.
Yep.
Appreciate you guys.
Same.
Ah, delicious. Yes, if you'll pour some of this into your son's throat after a tonsillectomy, he won't hurt anymore.
I'll tell you, it's so strange. He's like better after the surgery than he was before.
Yeah.
She came in and said, had a fantastic doc, Tangeti, familiar with her? But she said there was so much infection. The kid's been getting strep throat to the point where we stopped going to the doctor. We just went and bought strep tests, and we would just test them, and then we'd try a more aggressive antibiotic because my dad would help us write a script for it because that's what was going on. Save some money there. But over time, it's like, these got to come out. So right after the surgery, she said, listen, they were really infected, and they were harboring it all. So I think this is going to be good. He wakes up, he looks at me, and he goes, I can finally swallow. I was like, well, could you not swallow yesterday?
Wow.
He was like, I didn't feel like I could. I'm like, what? No. So the dude's like eating more than he has eaten since before the surgery, and this
He was starving.
yeah, we're 1 day post, man. He's a champ, so it's all going well.
Brand new little man. I like
I
it.
know.
Well, guys, I'm going to tell you, this has been a great episode for me. I like what you brought to the table, Alex. I always want to learn more about how this system got out of whack. It was interesting to hear that I would have never put Blue Cross and Blue Shield from those two entities together. And I'm excited to learn more. I don't know what you guys are thinking, but I think it's time to bring a guest in at some point. Who do you have, either one of you have anybody in mind? I know I've got a couple of them, so.
Well, absolutely. I mean, we've mentioned Dr. Smith. I think he'd be happy to come on. That guy is a wealth of knowledge in this world, and he knows a lot about the history too. I actually listened to another podcast that he was on, and he talked a little bit about the history of the county hospitals. That's where I got that tidbit. So he would be fun to have on. I think any of the groups that have put together these direct networks, whether it's Jay Kempton or Tracy Kreger. I'd love to have Tracy on. I mean, she's been at several different places and ended up starting her own deal. So she could even talk to the specifics of trying to do this in a traditional TPA environment, and how that worked and didn't work, and then what ultimately led her to her own venture. But, and then at some point, getting a direct primary care physician in here. I love the idea of Matt coming into for sure.
I think Matt and his crew, and talking about how PL Providers was formed and the travel that they've been on. I'd like to have a TPA in here. Jay Kempton's on my radar. I like the dude a lot. Yeah. Jay's a super good dude, and he likes a good whiskey. That's going to be a good thing.
That's our draw.
That's right. That's our draw. We'll actually.
And this Infinity decanter that we're about to put together is you're going to want to come on this show.
Absolutely. And the thing about it is he likes a good craft beer. He likes a good whiskey, but his whiskey's Scotch, and I'm not a Scotch drinker.
Yeah. He's an audiophile too, though.
He's an audiophile.
Oh boy,
he's got Macintosh equipment in his office, and he knows his stuff.
I'd love to chat with this guy. So, let's make it happen.
A lot of good opportunities. Guys, thank you for listening to us in the third episode of Healthcare Uncut Unfiltered. We look forward to getting back and hearing from you guys before long, and we appreciate you coming on and listening to us.